Hello everyone, and welcome to Softfill Academy's webinar. We are very happy to welcome all of you. I will start by introducing this webinar in order to give a bit of time to everyone to connect. First of all, I would like to give a warm welcome to Dr. Shady Ismail. Thank you so much for being a Softfill Academy expert, supporting the brand, and for, of course, doing this webinar with us.
Thank you so much, Hannah. Thank you all for your attendance. And today I'm so happy and thrilled to announce or to discuss the difference between needle and canula and lip injection, step-by-step approach, videos with the techniques, and anatomy. And I think anatomy is the most important thing because it's the base or the paramount for our safe practice. I think lips are the most demanded area all over our clinical practice. But we need to understand and to do it safely and to achieve a natural result. So it's a little bit complex because I think lips is a very tricky area. Either it's so beautiful and give us the feminine look, or it can be overdone and leads to the complication other than the vascular complication, like the unpleasant look, unpleasant appearance from the dark lips or the migration of fillers, which we see it a lot today. So thank you, Hannah, so much. And
thank you. I'll just give you a bit of technical information on the webinar. So the webinar will last maximum 1 hour. Dr. Shady Ismail is going to do his presentation, and then we will keep all the questions for the end. But don't hesitate to ask all of your questions in the chat or in the Q&A all along the webinar. Also, this webinar is being recorded. And it will be available if you're missing it or if you missed a part of it. It will be available from tomorrow on Softfill Academy's website. The webinar is also going to be subtitled from tomorrow. The replay will be available in French subtitles, English, and Spanish. I would like to now introduce a bit more about Shady. Could you please put the right slide on and share your screen?
Sure.
Great. Thank you so much.
So today we are in the series of Softfill Academy webinars. We are trying to do it remotely, but with videos as we are presenting in live demo. So we're discussing the lips, how to inject it using cannula or needle, which is safer, which is better for us in our practice. So we mastered the art of safe injection, and we all know nowadays that cannula, it's not just an option. I think it's mandatory, and this is the new norm for injection for certain areas of the face. So needle versus cannula from Egypt and from the pyramids. I'm a plastic surgeon, and I'm over 13 years experience in non-surgical procedure, and I'm owner and founder of Clarité Aesthetic Clinics in Egypt and in Dubai, and also I'm a Cardiff University Masters of Clinical Dermatology. Needle versus cannula for the lips. So this is our main subject. I just want to discuss briefly, is it cannula or is it needle? Because I attend a lot of lectures and I see people say I'm a cannula guy or a needle guy. No, it's not about just one tool. You have to understand how to use all tools to reach your goal or your what you need to achieve. So, which is better? Both work very well in the proper hands. I love cannulas because it can minimize the trauma, minimize the downtime. People nowadays are not accepting downtime or bruises or that because of the fast pace of life and the work activities. So we need to understand that. Using a safer tool with less downtime is the main concern in our practice. However, sometimes people can feel pain using cannula in the lips, and sometimes we can feel migration, but this is not about the cannula itself or the product itself, but about the hands of the injector. So it's injector dependent, which is safer. is the cannula safer or the needle? There is no 100% safe area of the face. We know it's all full of dangers. But cannula is much more safer in certain areas. But as long as I said in the beginning, if you know the anatomy well and you understand the anatomical knowledge behind our injection, our techniques, and the neurology of our products, you will be safe for sure and you'll achieve your result naturally. So whatever the tool is, as long as you know anatomy and achieving a natural result, it's okay for you. What are the pros and cons of using cannula over needle? The main difference between cannula and needle that the cannula has a blunt tip, so it minimizes the pressure against the tissues, minimize the swelling, minimize the downtime or the bruising that can happen, as we see here, and minimize also the incidence of vascular occlusion, because blunt tip means that I cannot get inside the artery in most of the cases, but we need to understand, even if I'm injecting with cannula, I have to be parallel or perpendicular to the course of the artery and in different level. So it's not only about the anatomy or illustration and the position of the artery, but in which layer the artery is. So if it's deep, I'm injecting superficial. If it's in the muscle, I'm injecting subcutaneously. If it's superficial, I'm going to inject deep, either using cannula or needle. So the position of the artery and also the layering. And the layering is extremely important. And cannula, one of the main advantages of cannula, that I can reach all the tubercles and all the vermilion border just from one point right, one point left. So I can treat all the lips from 2 entry points rather than injecting too much points. Also, maybe it's less painful for patients, and for other patients because of the movement, maybe it's a little bit painful, but as I said, it's injector dependent. So be soft, as we will see in the video, just be soft, don't be too harsh, don't be too aggressive, manipulate the tissues to allow the gliding of the cannula. Disadvantage, maybe if you are new to injection of the cannula in certain areas, you cannot be precise, or you can be at a different level or different depth. As I said, layer, or I want to inject superficially, but I'm too deep, so I'm in the muscle or I'm in the mucosa. So layering is very important. Try to manipulate, try to just be soft and gentle while injecting using the cannulas. Talking about the lips as one of the most demanded area nowadays in our clinical practice, lips are a symbol of beauty and usefulness. Lips with eyes and nose are the main attractive points. So when you talk to me, I look to your eyes. So eyes are the windows to the soul. Then I'm looking to your lips because I want to see what you're saying, then the nose. So these are the main attractive point. And also lips has a significant role in communication, speech, expression, and define the female attractiveness. Anatomy, as I said, base and paramount for our safe practice. So we need to understand first the microscopically anatomy features of the upper and lower lip. We have here, number 1, the philtrum column, and we have number 2, the cupid bow. And all over the lips, we have the vermilion border, which is a virtual channel between the white and the red lip. And we have the upper tubercles and the lower tubercles. If we took a sagittal cross-section of the upper lip, we'll have the intraoral part and we'll have the extraoral part. Intraoral part, we all know the muscle, orbicularis oris muscle. So here's the part, the inner part, which is orbicularis oris varus preferens, and we'll have also accessory salivary glands, as we see here, and the mucosa, and vessels, but vessels mainly intramuscular. And then the outer part, with the extraoral part, I will have the orbicularis oris varus marginalis muscle and the skin. We need to understand there's 18 muscle connected to the orbicularis oris muscle, hence it will affect the expression and the movement of the lips. We have the levators, we have the depressors. We need to understand which action the muscle is doing, because we can combine the fillers or the HA fillers in the lip injection with toxins to improve, like for instance, the gummy smile, if we have it, we can improve the downturn of the angles of the mouth, injecting in the DAO or the depressors. So briefly, we will have the levators, zygomaticus minor, zygomaticus major, levator labii superioris, levator labii superioris alaquanazi, and we will have the vaccinator and the risoris, which is responsible for the smile or the lateral smile. We'll have also the depressor dentalis, the DAO, the depressor anglioris, the depressor labii inferioris. So all the connection of the CT muscle, very important for the expression and for how we express our movement using lips. Put in mind, this is a highly expressive area. You need to understand the rheology of your fillers. We cannot inject just a very heavy, very high viscous, high G prime fillers in that area, because if we did so, we'll alter the movement. That will lead to migration, that will lead while we are smiling, kissing, talking, express ourselves. It will be odd. It's not normal movement of our lips. Lips, there's a large vascular system, so most probably when we inject unintentionally and a tiny droplet of filler inside the vessel, it resolves by itself most of cases. Why? Because there's a large and huge vascular network and anastomosis in the lips. If we see here, we all know that our main supply of the face is the facial artery, and it's a branch from the external carotid artery. Facial artery arises in the face in front of the masseter. Here, where it arises in the face, it's in 100% of population, it's on the bone. Then it becomes here tortuous. Why tortuous? Because it allows the dynamics and the movement of the facial muscles and the continuous movement of this area. Then it goes deep, but here not deep on the bone, here deep under the muscles. I have two landmarks here. We have here the DAO, and we have the zygomaticus major muscle. So it becomes deeper to the DO, and then it enters the lips as an inferior labial artery and superficially, and then dive deep, as we see here, to the mucosa from the lateral 1/3. Then under the zygomaticus major muscle, it enters the lips, upper lip from the lateral 1/3 as a superior labial artery and enters superficially, then dive deep inside the mucosa. If we see here the E to E, expert to expert, which is one of the largest platforms of anatomy in the world, we can see here the real diameter of the arteria labialis and how it's behind here, the zygomaticus major muscle, and here behind the DAO. And then it entered the lip from the lateral 1/3, and this is the real diameter in the cadaver, and we can see it dive deep till it reach the mucosa. If we see here the cadaver dissection video, we can see we peel the skin, so we see the arteria labialis. As we said, where's the artery? It goes from the facial artery, then deep. If we remove the first layer, which is the skin and the fat, we can see here the artery at the modulus is superficial, and it divides into two parts, as I mentioned before, behind or below the DAO and below the zygomaticus major muscle. Another arterial supply of the lips, which is a columellar vascularity. And here's a lot of variation, but we need to understand it's either single, which is most common variation, or double straight, so it can be double, or it can be forked. So we need to understand this vessel, these vessels are multi-layered, so it's in all layers. So during the cadaver dissection, we found it intradermally, subcutaneously, or inside the muscle. Here the fat is in the upper cutaneous part is so thin. That's why we experience the barcode lines, because of the action of the muscle over the skin. Layers of the lips, mainly three layers. We have the subcutaneous layer, which is the most superficial part, and we'll have the muscle, intramuscular, or we have the mucosa, submucosal, where we can inject at lower risk. Vessels here are of different depths depending on their location. So to understand where's the artery, so I can move away from it and inject safely. So if we look at this study by Kutfana et al. In the plastic surgery plastic and reconstructive surgery journal, so here we can see that there's a lot of variation. So 78.1% it's submucosal. So this is the most common area where the artery is. Intramuscular, it's 17.5, but only in 2.1 of population it's subcutaneously. That means that this is the most or the safest area and the less risky area. So where to inject? Inject in the less risky area, which is superficial. So as long as you are superficial, using the proper product to inject superficially, using the safer tool, so you are safe. Where's the artery is? The location of the artery. We have the white lip and we have the red lip. The red lip has two parts, the dry border, the dry lip, and the wet lip. In between them, we can see here the wet dry border. Here, where is the artery is? Either on the wet dry border, 2 millimeters anteriorly, or 2 millimeters posteriorly, or 2 millimeters inferiorly in the muscle. So mainly while I'm injecting, this is just small tips and tricks. I never cross the wet dry border. And when I inject superficially. When I inject, I choose the right tool. I choose the right product, so you are safe. What happens to lips due to aging? We can see here there is lengthening of the cutaneous upper lip, so increase of the nasolabial space. That's why when we inject to reverse the signs of aging of the lips, we need to evert the lips. We need to improve the vertical height of the lips. Development of the barcode lines or the wrinkles, flattening of the cupid bow. That's why we are trying to draw it again using fillers, as we will see in the videos, and also the filter cone. From the profile view, we can see because of loss of denture and maxillary retrusion, piriform fossa increase in size, and the chin becomes shorter and more anterior with aging, because as we know, aging happens through all the layers of the face, from the skin till the bone, affecting the skin, lose the elasticity, the radius, the complexion, fat compartments, the deflation or inflation according to the area, bone, there is resorption or deposition, muscles, hypertonic or hypotonic. So regarding that area here, change in the bone will affect all the soft tissue above it. So here we can see inversion of the lips. The lips becomes much more inside. And as I said, flattening and increase the size of the space between the length between the nose and the lips, which is the nasolabial space. Assessment. What should I do during assessment? I check the lips from anterior view to check the proportion, which is the percentage between the upper and the lower lip. Is it the golden ratio, the diamond ratio? Mainly according to the ethnicity, the gender, the race. So it's either 1 to 1.618, 1 to 1.4, or in some races 1 to 1. Then I check the symmetry, the shape, the projection from profile view. Do I need to invert it? Do I need to project it? Do I need to ensure the symmetry between the right and the lip? Do I need to ensure the proportionate lips between the upper and lower? And also very important, assessment in the lateral profile to check the Ricketts line, the relation of the lips with nose and chin, because there are many ways to assess the lower face with the nose, with the lips, okay, which is Burson line, Stein line, or the E. Ricketts line. Also, very important, the dynamic assessment during smiling, kissing, baby cry, so I can check if it's related to the muscle or the volume, or I have a gummy smile, so I can combine fillers with toxins to improve all this area. Global harmony of the face. Don't think about the lip itself, think the whole picture, so it's the peri-oral area. So usually when I inject the lips, I inject the lips, I check if I have barcode lines, I check if I have a libumental crease. Also, I can treat a little bit the marionette, because the marionette folds is not only because of the other two folds and I have to fill them. They are because of the downturn of the angle of the mouth. So I need to treat them from the lip itself, then I support from down. Techniques. We have many different techniques, but as I said, the safest technique is to inject superficially, choosing the proper rheology of products, either cannula or needle. Your preference, for sure, cannula is much more safer than needle, but if you are experienced to inject with needle at the right level and you know anatomy, so it's safe also. So injecting mammalian volume for definition and projection. If I want volume, I will inject in the subcutaneous plane. Intramuscular, it will increase the volume, which I will not recommend, because this is a highly expressive area. So injecting in the muscle while expressing, talking, that will lead to, as I said, extrusion of the fillers, so you can check lumps and bumps. Injecting inside the mucosa, unfortunately, it will block the lymphatics of that area, so we can see the jellyfish appearance, or I say, what I say, a curtain lip. So while they are smiling, I can see the mucosa like curtains. So what I prefer is injecting the vermilion border in the subcutaneous plane superficially. Cutaneous injection may be visible, so choose the right product that can integrate and can be massaged easily with no lumps or bumps. Use a small amount of product and use a soft gel, not a stiff one. Now we're checking the techniques. So together, I'm going to discuss the video. Here's my colleague Nada. She's 34 years old. Here I used Softfill Canula 25G, 50 millimeter, and the entry point, I'm using here RHA2 Tucial, which is a viscoelastic product that can integrate easily and makes no lumps and bumps. Here I'm going through the opening I did, and I put here lidocaine with epinephrine, just a tiny droplet to control the bleeding. I enter manipulate easily. Sorry, I think the video freezed. Yes. Then I enter superficially, I manipulate. But here I'm not too superficial because I want to inject the body of lips itself. Here I can see the cannula moving, but I'm not too superficial because here I want just to give volume. But I'm not in the muscle. So here I'm in subcutaneous, I'm injecting tiny amounts, retrograde, in a fanning manner, micro droplets. And the product is not visible. I'm advancing my cannula easily. Another line. So I'm making like 3 lines. Here I will use the same entry point. As I said, I minimize the entry points, so I minimize the risk of edema, bruising, downtime, and I'm entering the lower lip. Also, I'm injecting the body of the lip itself. I'm advancing my cannula. I can see the cannula moving, but not too superficial. I'm injecting multi-level. Here I find resistance. I will use my other hand, my non-dominant hand, just to guide me and to ease the entrance of the cannula softly. As I said, it is soft fill, so filling with a soft and precision, softly and with precision. Here, another line, I'm entering, there is a resistance, I don't push because I don't want to induce any trauma or bleeding. And then I'm injecting another line, and I stop. On my way out, you can see the cannula, there is like a demarcation here, so I stop, I know where to stop, because I have to stop before this entry point, because I don't want to accumulate the fillers, because we all know there is something called a retrograde backflow of fillers. Here, I'm entering with cannula, manipulating in the vermilion mode. You see now, it's too superficial. And I'm leaving a droplet in the JK points. So I can use also the cannula to define the lips. It's not only about filling, but also I can define the lip itself. Now, from the same entry point, I will inject also, as I said, the perioral area. So I'm going to inject the downturn of the mouth, and I will inject here the part of marionette, the upper part of marionette fold, to enhance the full picture. Here, the other side, entry point, same concept. Just tiny prick, as you see, I'm so superficial because in the opening will guide me through the level of my cannula. I'm cleaning. And as we see here, I'm entering with cannula, also all the way injecting the body of the lips itself, 3 lines, and then I'm entering the lower lip, injecting the same technique. I'm cleaning. Then I will enter to inject and to improve also the marionette, as I said, the downturn of the mouth, of the corners of the mouth. Here I'm a little bit superficial, as I said, and I'm going here superficial to leave the droplets in the JK point. Here I can see the tip of my cannula. I push against the JK point, and as we see, there is no pain, maybe a little bit discomfort or irritation, as long as you are moving softly with no aggression, and you minimize the risk of bruising and edema. Now I will combine using needle, just the cupid bow to enhance it. As I see, I'm too superficial entering from JK point immediately, and I contain the filler within my fingers. I press and I release. Then another point. So it's not about cannula only, needle only, and this is the main aim of this webinar, that we need to use the tools in our hands to achieve a good result, naturally, as we see here. Then I will give a tiny droplet at JK point so I can increase the vertical height of the lips. Just a tiny droplet, as you see with the tip of my needle, and I leave a tiny droplet. Now, which is most important part, massage. Massaging the lips is very important because I don't want to leave my patient leaving my office with lumps or bumps or irregularities. So I'm using my fingers, my fingernails, just to scratch the lips so I can feel no lumps or bumps. I'm safe. I don't want to be asymmetry, so I can check it while massaging. Here we removed. And then we can see now the before and after pictures, and during expressions, I have to assess my patient after injection during expressions. So smiling, so kissing. Now this is before and after pictures. 0.5 view, you can see the definition. Also, these points can define the facial corner without injecting them during smiling, symmetrical, and during kissing, obviously. Now, our second case, this is lip assessment during dynamics. Here, as I said, the facial artery divides into two parts, superior and inferior labial. The superior labial under the zygomaticus major and the inferior labial under the deo continues as it ends as an angular artery. Inspection of the artery and palpation, usually it's deep in the mucosa, and here is in the wet-dry border, so it lies in this area. I mark my projection. My projection will be just between the two areas of the nose. Here I'm using a needle. I will start with my JK point all the way deep and before the wet-dry border, as we see, because I don't want to accumulate the fillers here, and then I leave a tiny droplet on my way out. We can see immediately with 1 point how the vertical height and the definition increase from one side to the other. Then this is called the tenting fencing technique. I'm using the needle gently all the way to improve the lip, and we can see immediate difference between both sides, and then I injected to improve the cupid bow. Also, the same technique in the lower lip, I inject the two tubercles paramedian, and then I can enhance the symmetry. Then here, I'm just smoothing out the lines and the wrinkles of the lip itself. You can see here a keyhole out. And then I'm putting like a moisturizer for the lips, massaging the lips, and you can see during the expression, there is no alteration or movement. You can see the before and after pictures, anterior view. So this is before and after, full face view, zoomed view, with two lateral views. Complication, which is very important part, because we are talking about Softfill, we are talking about Canula, safe techniques, so I'm going to talk about the complication. We have two ways of complication: the vascular complication, avascular complication, or the aesthetic complication, which is common, which is edema, granuloma, nodules, hematoma, which is most common, and it's reversible and it can resolve by itself. We need to take a full and good history about our patient, about using blood thinners, anticoagulants, taking medications, and we need to understand the depth of the injection and choosing the proper rheology of the product, choosing the right tool and the safer tool. If we have a vascular complication, which is very rare, as we see here, the percentage 1 to 6,558, and this is because of the poor knowledge of the anatomy and the injecting, like we are imitating the social media. We just begin and inject in any level or injecting from inside. If you know the course of the artery, inject against it, and that's it. You will be safe. And don't inject unless you know how to treat the complication. So I'm sorry, I'm going to go back here a little bit. Those complications needs time and proper medication. This needs immediate intervention, like injecting Hyalase and aspirin, and we need to do hot foment, warm foment, and massage, and follow up with the patient. Never run away with a vascular occlusion. Diagnose it quickly and treat it, and you have to have Hyalase. So check the patient history, understand the 3D facial anatomy during dynamics and static position, know the rheology and dynamics of the fillers, inject in the correct tissue plane with the right device with the correct amount of product. Most common side effects nowadays we see sausage lip or throat pout. We can see oversized lip, projection of the lips. So this is unacceptable, unpleasant look, stiff and unnatural during speech because of high cohesive gel injecting the lips, inability to pose the lips together. Then the filler mustache, which is migration of fillers. That's why I entered from the white lips. So there is a retrograde backflow of fillers through the needle pathway, leads to accumulation of fillers, either on the lower cutaneous lip or upper cutaneous lip. So we need to enter, as we saw in the video, just from the vermilion border in the red lip itself and choose a proper product of fillers, injecting viscoelastic product in the right level, superficially, and proper filler placement. Simplicity, beauté, elegance. This is my my clinic theme and slogan, and I think this applies also to the lips. I need it simple with beauty and elegant. See you soon, my friends. Follow me on Instagram if you need to ask any question. I'll be of help, and I'm so happy to present this webinar. For any questions, send me anytime, and I'm here. I'm always here for you. Thank you so much. Thank you, Softfill, for allowing me this opportunity.
Thank you so much, Shady. It was amazing. Very, very interesting presentation. I think everyone really loved it. We already have a question for you, actually, from Brenda Pattern, that is asking, how do you typically treat the filtral column, with a cannula or with a needle?
Okay, regarding the filtrum column, let's revise. There is a huge variation of the artery, so either single or a double or forked. And as I said, it's multi-layer artery, so it can be superficial or deep. So most probably I'm injecting it using a very thin needle. I put the lower third only, I treat only the lower third of the filtrum column. I enter from the JK point till the lower third. I contain the fillers, injecting superficially, aspirate and wait and inject tiny droplet. But by the way, while injecting the two GK points and leave a tiny droplet as we saw in the video, it also extends to the lower third of the filtrum column, so it will be defined. And injecting filtrum column, it was an old school because now it looks overdone, and we need to enhance and beautify our lips. We say it lips beautification without augmenting or appear to be at overdone lips.
Thank you very much. Are there any more questions? You can ask them in the Q&A or in the chat here. All right.
Thank you.
Okay, so we have a question if you prefer to inject filtrum.
Yeah, as I just answered now, usually I don't do them because it will be overdone. Just injecting the lower third and injecting just in the JK points, and it will extend a little bit and elevate the lip itself.
Thank you. What size of needle do you use when injecting the lips?
Minimum, I'm using 30. If I'm using soft fillers with specific rheological properties, which is soft yet elastic, I'm using like 32, 34. But I don't want very small needles, because if I do a pressure, this will increase the incidence of vascular complications. I don't want to increase the pressure on the plunger.
And what size of cannula do you prefer for the lips?
I think ideal size of cannulas for the lips is 25, either 40 or 50 millimeters. So it can reach all the tubercles and all the parts of the lip from one entry point. So minimum opening and minimum downtime and bruising.
Great. Thank you very much. I think we don't have any more questions. Everything was very clear. I just want to say to everyone again that the webinar was being recorded, and it will be available from tomorrow on Softfill Academy's website. It will be also subtitled in French, in English, and in Spanish. Thank you very much to everyone. Then thank you, Dr. Shady Ismail. It was really interesting.
Thank you so much. Thanks for the 90 people who attended the webinar. Any questions, don't hesitate to send me. Thank you, Anna. Thank you, Softfill, and together. Thank you all.
Great. Bye. Have a good evening.
Time to inject lips in my clinic. Thank you.
Yes, definitely.
See you all.